So now we cover the median nerve. Here you see the axillary artery lying in the axilla in front of the subscapularis and the triangular and quadrangular space. There is the lateral cord and the medial cord, lateral and medial to it. The median nerve is formed by the communication from both the lateral and the medial cord and lies on the lateral side of the artery. Then notice that in the middle of the arm it crosses from lateral to medial, and therein it keeps on lying medial to the artery. After crossing the elbow, the median nerve would pass between the two heads of the pronator teres, the humeral head, which is this one, and the ulnar head, which is this one. So it will pass between these two heads of the pronator teres, and the brachial artery would divide into the radial and the ulnar artery. The ulnar artery will cross the median nerve from lateral to medial, separated from the median nerve by the ulnar head of the pronator teres. Now this is a very important relation, because you have to release the pronator origin in an operation called as the Max-Page operation. Max-Page operation, which is done for chronic Walkman's ischemic contracture. And there you have to first release the humeral head, then you have to release the ulnar head, which is basically lying between the nerve and the artery. And when you release this ulnar head, you have to release it in a manner that both the artery and nerve are saved. So Max-Page operation and this relation is extremely important. Then after passing through the pronator teres, it passes between the two heads of the flexor digitorum superficialis and comes to lie deep to the flexor digitorum superficialis between the flexor digitorum profundus on the ulnar side and flexor pollicis longus on the medial side. 5 centimeters above the wrist, it gives a palmar carpal branch which supplies the thinner skin over the thinner eminence of the hand. Then it crosses the pronator quadratus. It supplies all the muscles of the forearm except the flexor carpi ulnaris and the third and fourth of the flexor digitorum profundus, which is supplied by the ulnar nerve. And after crossing the pronator quadratus, it comes to lie deep under the carpal ligament, connecting the paciohamate ligament to the lateral side of the scaphoid. And here in the carpal tunnel, it is lying between the palmaris longus and flexor carpi radialis. Then, after crossing the carpal tunnel, where it can be entrapped and can be subjected to pressure, causing the carpal tunnel syndrome, the nerve divides into a superficial and a deep branch. The superficial branch of the median nerve supplies 3.5 fingers and communicates with the superficial branch of the ulnar, which supplies the rest of 1.5 fingers. So they go into the web space and divide into digital nerves, which supply adjacent areas of the fingers. So this is the superficial nerve. The deep nerve passes between the flexor pollicis brevis and abductor pollicis brevis, pierces the opponents, and ends in the first and second lumbricals. So this is the course of the median nerve. Now the tests. So you test the abductor pollicis brevis, which is called as the pen test. Then there is a pointing index. You ask the person to clasp both wrists. So when he makes a fist, he cannot flex the index finger because the FDS is paralyzed and because the first FDP is paralyzed. The second FDP gets a slip from the third and fourth, which are supplied by the ulnar nerve, and therefore even the second finger can flex, and only there is a pointing index which indicates the paralysis of the median nerve, which is a high paralysis. The low paralysis, the pen test, abductor pollicis brevis, high paralysis, the pointing index, besides the sensory loss. So how do you treat the residual paralysis? Opponence is the rotation of the metacarpal so that the the thumb starts opposing the flexion of the fingers. So that movement is called as opponence. Basically, it's the abductor pollicis brevis which brings it about. And so you substitute the abductor pollicis brevis by the FD, flexor digitorum superficialis of the third finger. Now there are two techniques to do it. One is called as the Riordan's technique, the other is called as the Brandt's technique. But we'll not go into the detail of those techniques. The prerequisite is that there should be no adduction contracture. If there's adduction contracture, you would not be able to do this. You would not be able to do this. Then the joint, carpometacarpal joint at which this movement is occurring, should be painless and stable. Normal, painless and stable. Other muscles that can be used are abductor digiti minimi. Abductor digiti minimi can be used from here. This muscle can be detached from here and used as abductor pollicis brevis. The operation is called as Littler's transfer. Or you can use the insertion of, you are seeing the thumb from the back and this is the index finger. So you can use the extensor pollicis brevis tendon from its insertion and provide a motor onto this, which can cause the opponence. So this motor can be remembered. Flexor carpi radialis, palmaris longus, flexor carpi ulnaris, extensor digiti minimi, extensor carpi radialis brevis. This operation is called as the Phelan-Miller transfer, fixed insertion transfer. Here you are using the insertion of the extensor pollicis brevis. Now then there can be a carpal tunnel syndrome where the nerve is compressed, especially on flexion of wrist. There can be algesia or pain in the distribution of the 3.5 fingers, or there can be anesthesia. Rarely there can be any motor involvement or wasting. The condition is treated by steroid injections which may treat inflammation and reduce swelling, or decompression by incising the palmar carpal ligament.